Keeping a severely premature infant alive requires pushing the boundaries of medicine, but the very interventions that save their lungs and brain come with a hidden cost to their eyes. We call this retinopathy of prematurity, or ROP. This diagram shows the normal anatomy of the eye. Notice the retina lining the back cavity. In a full-term pregnancy, blood vessels have time to grow all the way out from the optic nerve to the edges of this tissue. When a baby is born early, that growth completely stops. Because the clock ran out, these outer edges of the retina are left essentially bare. They don't have a blood supply. This creates a highly vulnerable avascular zone that is starving for oxygen. To keep the infant alive, we use supplemental oxygen, but preemies experience constant fluctuations in their oxygen levels. Every time those levels drop, the oxygen-starved retina panics and releases a surge of a protein called VEGF. That protein acts like a hyperactive fertilizer. It forces new blood vessels to grow rapidly, but these aren't normal vessels. They are fragile, disorganized, and prone to leaking. The medical team is caught in a physiological bind. The oxygen therapy required to keep the baby breathing creates an environment that directly attacks their vision. We know exactly who is at risk. Any infant born weighing less than 2,000 grams or born before 34 weeks of gestation is immediately placed on the mandatory screening list. For these at-risk infants, the very first retinal exam must happen at exactly 4 weeks postnatal age. But if the infant is extremely small, under 1,200 grams or born before 28 weeks, that window shrinks. They need to be screened between 2 and 3 weeks of age. Missing this window gives those fragile blood vessels time to contract and pull the retina completely off the back of the eye. Preventing this requires rigid NICU protocols, like putting bright, color-coded placards directly on the incubators so nobody misses the date. If a child goes blind because the clinical team missed the screening date, that is an administrative failure. It means the hospital system broke down. This diagram maps the disease's spread. Stage 1's thin line progresses to Stage 3's aggressive tissue growth. In milder stages 1 and 2, growth hasn't entered the vitreous fluid. This is type 2 ROP, which resolves on its own in 90% of cases. If you diagnose type 2, your treatment plan is patience. You don't operate. You wait and you re-examine the eyes every 1 to 2 weeks to ensure the vessels are maturing properly. Type 1 ROP is the exact opposite. It is an immediate clinical emergency. If you see this, the patient needs intervention right away to save their sight. The clearest indicator of type 1 is plus disease. Look closely at this image. These vessels are highly dilated, engorged, and twisted under immense pressure. As the examining physician, your job boils down to this critical distinction. You have to correctly identify which infants just need time to heal and which ones need to go straight to the operating room. When a patient hits type 1, you have to choose a treatment. You are deciding between the permanent structural certainty of a laser and the tissue preservation of an injection. This chart shows the trade-off. Laser ablation is incredibly effective, intentionally destroying the retina's avascular edges to permanently stop VEGF production. But look at the x-axis. The cost of that permanent fix is sacrificing the child's peripheral vision to save the center. This is a diagram outlining the zones of the eye. When the abnormal vessel growth happens right in the center, here in zone 1, we turn to the alternative, intravitreal injections of an anti-VEGF drug, like bevacizumab. The injection chemically neutralizes the protein. The abnormal vessels shrink back quickly, and you don't have to burn any tissue. The child keeps their full field of vision. However, the medication eventually wears off, and when it does, the disease can rapidly reactivate, triggering aggressive, unpredictable vessel growth all over again months later. You skip the tissue destruction of the laser, but you inherit a massive compliance risk. You're sending the infant home during a dangerous window where they could still go blind. Inside the NICU, the baby is surrounded by alarms and continuous monitoring. The moment those sliding doors open and they go home to the chaotic reality of outpatient care, that safety net disappears entirely. For the infants who received the anti-VEGF injection, the highest danger happens out there in the community, potentially months after they're discharged. This chart shows the required follow-up schedule. The clinical team must relentlessly track and examine the infant's retina well past their original due date, all the way until they reach at least 65 weeks post-menstrual age. This graphic shows stage 5 ROP. If a family misses their outpatient appointments and the disease reactivates undetected, the vessels will pull the retina completely off, resulting in total detachment and permanent blindness. You can perform a flawless, life-saving injection in the hospital. But if your discharge scheduling system fails to bring that baby back for follow-ups, the treatment ultimately fails. The final step of the process happens with the parents. You have to explain retinal pathology in a way they can actually use, without sending them into an unnecessary panic. If the infant has mild type 2 disease, don't jump to words like blindness. Tell the parents their baby has immature blood vessels that just need to be watched while they finish growing. If they have severe type 1 disease, tell them vessels are swollen and need immediate help to stop permanent scar tissue from forming. Most importantly, you must give the parents specific physical warning signs they can look for at home to catch late-stage complications. Tell them to watch for 2 things: leukocoria, which is a visible white scar tissue deep inside the baby's pupil, and nystagmus, which is an involuntary, rapid back-and-forth movement of the eyes that they might notice at home. Never tell a parent to just follow up with an eye doctor. You have to write the exact date, exact time, and the physical clinic address directly on the discharge paperwork. The medical interventions keep these infants alive, but it is clear, systematized communication and rigid scheduling that ultimately protects their vision.